Let's talk about the abdominal wall. And look, it's so much more than just a container for your organs. The way you really need to think about it is like a clinician's GPS. This is the map that's going to guide every single physical exam, every diagnosis, and every surgical cut you make. It's absolutely fundamental.
So here's how we're going to break it all down. First, we'll map out the surface of the abdomen. Then we're going to deconstruct the wall, layer by layer. We'll get into the details of the rectus sheath, check out its wearing and plumbing, and then zoom in on a major weak point, the inguinal canal. And we'll finish up by nailing down the difference between direct and indirect hernias for good.
All right, part one, mapping the abdomen. You know, in the clinic, everything starts on the surface. Before you can have any idea what's going on inside, you have to be an expert on the map on the outside.
And that's really the core principle here, right? The body gives us all these external clues about what's happening internally. So learning to read this map is job number one. Let's start by finding our key landmarks.
Okay, so these are the big ones, the landmarks you can actually feel on a patient. You've got that sharp xiphoid process at the top. You can trace down to the umbilicus, and then feel those bony parts of the pelvis, like the iliac crest and the anterior superior iliac spine, we just call the ASIS. These aren't just random bumps. They are the coordinates for our clinical map.
So how do we actually use these landmarks?
Well, while anatomists love their super detailed 9-region system, in a busy clinic or an ER, no way. We keep it simple. We just draw 2 lines, one straight down the middle, the median plane, and one across the belly button, the transumbilical plane. And just like that, you've got 4 quadrants. It's fast, it's effective, and it's the clinical standard.
And why does this matter? Well, it's because each quadrant is like a zip code for major organs. You hear pain in the right upper quadrant, your brain should immediately go to the liver and gallbladder. Pain in the right lower quadrant, the appendix has to be at the top of your list. This simple grid is your first step to figuring out what's wrong. All right, section 2. Now that we've got the surface mapped out, it's time to go deeper. We're going to start peeling back the layers of this wall, one by one, starting from the skin and going all the way down to the peritoneum. And this isn't just a thought experiment. This is the literal path a surgeon's scalpel takes. You cut through skin, get through that subcutaneous tissue, separate 3 layers of muscle, and then very carefully dissect through some special fascia before you hit that final delicate lining, the parietal peritoneum. Okay, let's pause for a second on one layer here, because this is a big one for exams. Scarpa's fascia. This is not just any old fatty tissue. Below the belly button, it becomes this tough, membranous sheet that's actually strong enough to hold stitches. And here's the key part. It fuses to the fascia in the thigh. This creates a wall, preventing fluid, like urine from an injury, from tracking down into the legs. A super high-yield clinical point. Next up are the muscles. You've basically got 3 flat sheets that wrap around you, the external and internal obliques and the transversus abdominis. They support everything, compress your insides, and let you twist. And then, running straight up and down is the rectus abdominis. Yep, the six-pack muscle. Now, the flat muscles don't end in normal tendons. They form these wide, flat sheets called aponeuroses, and those are going to be critical for our next topic. And all those aponeuroses, they all come together to create the rectus sheath. And trust me, this is way more than just about looking good. It's a really complex, multi-layered sleeve that wraps around the rectus abdominis, and its anatomy is a total favorite on board exams. Okay, so here's the crucial detail. There's this landmark called the arcuate line. Above this line, the rectus muscle is totally wrapped up, front and back, by those aponeuroses. But below the arcuate line, something big changes. All 3 of those aponeuroses swing around to the front. This means the back of the lower rectus muscle is basically left wide open, with only a thin layer of transversalis fascia behind it. And that creates a potential weak spot. And this is where it all clicks. A C-section is the perfect real-world example of this anatomy in action. A surgeon has to go through these layers, in order: skin, Camper's, and Scarpa's fascia, open the front of the rectus sheath, separate the rectus muscle, then cut through the transversalis fascia and peritoneum, and only then do they reach the uterus. It's like a living anatomy lab. Okay, so we've built the structure, now we've got to install all the wiring and plumbing that keeps it running. In other words, the nerves, vessels, and lymphatics. You know, the nerve supply follows this really beautiful, simple pattern. Just remember, T7 is at the xiphoid process, T10 is at the umbilicus or belly button, and L1 covers the inguinal region down below. And the clinical tie-in here is a classic. Early appendicitis irritates nerves that feed into the T10 spinal level, so the patient feels this vague pain right around their belly button, way before it ever moves to the right lower quadrant. The blood supply is just as elegantly organized. The wall gets fed from above by the superior epigastric artery and from below by the inferior epigastric artery. And here's the cool part. These two vessels meet up and connect right inside the rectus sheath. This isn't just neat. It creates a vital backup route, a collateral pathway for blood to get from the upper body to the lower body if there's a problem. Now for the veins, there are two famous clinical signs you've just got to know. First is caput medusa. If you have bad liver disease, pressure builds up in the portal vein, and blood backs up into tiny veins around the belly button, making them swell up like a bunch of snakes. Second, if the massive inferior vena cava gets blocked, the thoracoepigastric vein can enlarge to create a bypass, rerouting blood up to the superior vena cava. Okay, section 5. Everything we've discussed so far, all this anatomy, has been leading us to one critical region. We're now at the inguinal canal, a true hotspot of clinical anatomy and, as it turns out, a natural weak point in the wall. Which kind of begs the question, right? With all these strong muscles and tough fibrous layers, where is this wall most likely to give out? Well, the answer lies in this little tunnel that's formed during our development. The inguinal canal is this short, angled passageway with 4 walls. You've got the external oblique aponeurosis holding up the front. The roof is made of these arching fibers from the internal oblique and transversus abdominis. The floor is the tough inguinal ligament. But the back wall? That's our weak link. It's mostly just that thin transversalis fascia, which makes it super vulnerable to pressure from inside. And this weakness leads us directly to our final and probably most high-yield topic of all, inguinal hernias. Being able to tell the difference between the two main types, direct and indirect, is a core clinical skill, and the key to it all is one specific landmark. If you remember one sentence from this entire explainer, make it this one. When it comes to inguinal hernias, the relationship to the inferior epigastric vessels is absolutely everything. It's the one thing that will definitively tell you which type you're dealing with. Let's break this down. An indirect hernia is lateral to the inferior epigastric vessels. It's usually something you're born with, and it follows the entire path of the inguinal canal. A direct hernia, on the other hand, is medial to those same vessels. It just punches straight through that weak back wall in an area we call Hesselbach's triangle. This one is acquired. It's from years of strain. Lateral versus medial. That is the definitive difference. So we'll end with this. We've gone from a simple surface map to the deepest layers and pinpointed their weak spots. So now, with this incredibly detailed anatomical GPS in your head, how does that change the way you think when a patient walks in and just says they have abdominal pain? You now have the map to find the answer.